Bone tumors develop when the rigid cycle of skeletal cell division fails. Mutated cells replicate without limit, piling into an aberrant mass. This growth is driven by a specific genetic imbalance. Mutated proto-oncogenes overstimulate division, while broken tumor suppressor genes fail to trigger the cell death needed to keep the population in check. If the mass remains encapsulated and confined to its local tissue, the tumor is classified as benign. If the cells breach those boundaries to invade surrounding tissues or enter the blood and lymph systems, the tumor is malignant. When these malignancies originate directly from native bone cells, they are primary tumors. However, most bone tumors are secondary, metastatic cells that traveled from the breast, prostate, lungs, thyroid, or kidneys to take root in the skeleton. The behavior of an abnormal mass depends entirely on the specific cell type that mutated and the genetic errors driving its expansion. Clinicians classify these tumors by mapping them onto a spatial coordinate system. A long bone is divided into 3 distinct zones: the epiphysis at the ends, the central shaft or diaphysis, and the metaphysis, the region containing the growth plate. The second axis of this map tracks the resident cells, osteoblasts, which build bone tissue, and osteoclasts, which break it down. Within the marrow, primitive mesenchymal and neuroectodermal stem cells also reside, capable of differentiating into various tissue types. Identifying a tumor requires plotting it on this system, cross-referencing the mutated cell type with its exact anatomical location. The distinct shadows and patterns observed in clinical imaging reflect these underlying cellular and spatial interactions. In the metaphysis, the most common benign tumor in young males is the osteochondroma. Mutations in EXT1 or EXT2 genes disrupt growth plate regulation, producing a lateral bony projection called an exostosis. This stalk is typically covered by hyaline cartilage. Shifting the focus up to the epiphysis reveals the giant cell tumor. Following trauma or radiation, osteoclasts can mutate and fuse into massive cells with over 50 nuclei. These giants aggressively erode local bone matrix. This localized destruction creates multicystic lesions on an X-ray, appearing as soap bubbles. Moving to the diaphysis and the axial skeleton, we find 2 benign tumors originating from osteoblasts, osteoblastoma and osteoid osteoma. Both tumors form a nidus, a disorganized core of blood vessels, trabeculae, and unmineralized osteoid. In osteoblastomas, the nidus exceeds 1.5 centimeters, often eroding flat bones of the axial skeleton, like the mandible. Osteoid osteomas feature a smaller nidus, usually under 1.5 centimeters, and are typically surrounded by a dense ring of sclerotic bone. This sclerotic ring produces prostaglandins, molecules that trigger localized bone pain that is notably worse at night. Although these tumors are benign, they cause significant symptoms through mechanical erosion and chemical signaling. Malignant tumors in the metaphysis behave far more aggressively than benign ones, actively dismantling the bone's intricate architecture from the inside out. This is the site for osteosarcoma, the most common primary malignancy in adolescence. Mutated osteoblasts overproduce osteoid tissue so rapidly that the expanding mass lifts the periosteum away from the bone shaft. This growth is linked to mutations in the RB1 and TP53 genes, which remove the biological brakes on cellular division. This results in 2 classic X-ray markers, a spiky, radiating sunburst appearance, and the formation of Codman's triangle where the periosteum was lifted. In the diaphysis and sacrum, we find Ewing sarcoma, which primarily affects adolescents and young adults. It is caused by a chromosomal translocation between EWSR1 on chromosome 22 and FLI1 on chromosome 11. This translocation is often remembered by adding chromosomes 11 and 22 to get 33, the Jersey number of Patrick Ewing. The mutation creates sheets of small, round blue cells. As they expand within the diaphysis, the bone reacts by depositing new tissue in concentric layers. On an X-ray, these layers create a laminated appearance known as onion skinning. In elderly patients, the coordinate map points to chondrosarcoma, often found in the pelvis. Here, malignant cartilage cells hollow out the medullary cavity, producing patchy lesions that appear moth-eaten on imaging. Unlike benign masses, these malignancies obliterate their initial zones and destroy the structural integrity of the skeleton. Malignant bone tumors create threats far beyond the initial mass. As they expand, they compress vital adjacent structures. Compression of spinal nerves causes limb weakness. while the blockage of major vessels leads to avascular necrosis. The body responds to the malignancy with systemic inflammation, causing fever, night sweats, and weight loss. The most dangerous complication occurs when malignant cells enter the bloodstream and lodge in the lungs. This metastasis causes secondary pulmonary symptoms, such as chronic coughing and shortness of breath. An invasive bone tumor is a systemic condition capable of affecting vital organs throughout the body. When plotted on the coordinate system, clear patterns emerge by location. Diagnosis starts with medical imaging to identify the physical footprint. Serum markers then confirm genetic identity. Benign tumors require surgical excision to relieve pain. Malignant tumors need surgery, radiotherapy, and chemotherapy to prevent metastasis. By reconciling a tumor's cellular identity with its location in the skeleton, clinicians can isolate the specific pathology and execute the correct life-saving intervention.